Flexorplasty, elbow, e.g., Steindler type advancement. With extensor advancement. To perform a Steindler type advancement for flexorplasty of the elbow, the physician transfers the common origin of the prona teres, flexor carpi radialis, palmaris longus, flexor digitorum sublimis, and flexor carpi ulnaris from the medial epicondyle of the humerus proximally and laterally onto the anterior surface of the humerus so that it performs elbow flexion rather than forearm pronation. This is done when the biceps brachii and brachialis are paralyzed. The physician makes a curved longitudinal incision over the medial side of the elbow extending over the medial condyle area and along the prona teres. The ulnar nerve is identified and retracted for protection. The common origin of the prona teres, flexor carpi radialis, palmaris longus, flexor digitorum sublimis, and flexor carpi ulnaris is detached as a whole from the medial epicondyle. These muscles are freed up for about 4 cm. A fasciolata graft is taken from the lateral thigh and one end is sutured to the common origin to extend it, while the other end is advanced and attached 5 cm up the lateral side of the humerus. A cast is applied with the elbow in flexion. In 24331, an anterior transfer of the triceps, extensor advancement, is performed in conjunction with elbow flexorplasty. A posterolateral incision is made over the lower upper arm. The triceps tendon is exposed and divided at its insertion, dissected from the back of the lower humerus, and brought around to the lateral side. An anterolateral curvilinear incision is made to expose the radial tuberosity. Another 4 cm long fasciolata graft is harvested and attached to the triceps tendon to extend it for advancement. The other end of the fasciolata graft is attached to the tuberosity of the radius. This creates added elbow flexibility. A cast is applied with the elbow in flexion. Tenoplasty, with muscle transfer, with or without free graft, elbow to shoulder, single, Sedenbrooks type procedure. The physician makes an incision from the deltopectoral groove to the mid-portion of the upper arm. The pectoralis major tendon is exposed through dissection, detached from its insertion, and mobilized from the chest wall toward the clavicle. The tendon of the long head of the biceps is exposed and severed from its origin and withdrawn into the wound. The long head of the biceps is dissected from the short head. An L-shaped incision is made over the anterior aspect of the elbow. The long head of the biceps is divided and freed distally to its attachment on the radius. The biceps tendon and muscle are withdrawn through the distal L-shaped incision. Through the proximal incision, the tendon and muscle belly of the long head of the biceps is passed through 2 slits in the tendon of the pectoralis major and looped on itself so that its proximal tendon is brought into the distal L-shaped incision. The end of the proximal tendon is sutured through a slit in the distal tendon and the tendon of the pectoralis major is sutured to the long head of the biceps at their junction. The incisions are repaired in layers using sutures, staples, and slash or stri strips. A posterior plaster splint is applied with the elbow in flexion.